This will be the first, hopefully, of several videos that will be posted in this channel, which will tackle several topics in either clinical or anatomic pathology. This is a way for me to motivate myself to review these topics, and well, it won't hurt if it helps someone else in their studies too. So in this video, I'll be discussing the ICSH recommendations for the standardization of nomenclature and grading of peripheral blood cell morphological features. This article or guideline was first published online in March 2015, and last I checked, there has been no major updates for this guideline. They did publish an update regarding grading or quantitation of schistocytes, but there is a separate publication for that one, and I might discuss that in another video, maybe. And by the way, the link to the ICSH recommendations will be on the description, so you can always refer to their definitions, tables, and image database. This is the outline of this report, which includes a brief background and introduction to ICSH, including the rationale for this article or guideline, a very brief discussion on how this consensus article came to be will be next, and then the discussion on the grading of morphological features and recommendations will be next, and a summary of the report. The ICSH, or the International Council for Standardization in Hematology, was initiated as a standardization committee by the ESH in 1963 and was officially constituted by the ISH and ESH in 1964. It coordinates working groups of experts to examine laboratory methods and instruments for hematological analysis, to deliberate on issues of standardization, and to stimulate and coordinate scientific work as necessary towards the development of international standardization materials and guidelines. For our hematological analyzers, the presence of qualitative flags and/or quantitative abnormal results may indicate the need for peripheral blood film review and/or manual differential counts. Examples of flags are presence of blasts, immature grands, atypical lymphocytes, or problems with RBC morphology such as anisocytosis, microcytosis, macrocytosis, etc. However, there are various ways of reporting abnormal morphologic findings, such as the use of simple description, use of terms such as present or absence, semi-quantitative determination like mild or 1+, moderate 2+, or marked 3+. And finally, quantitative reports like the percentage of certain abnormal morphological findings. This marked variation in blood film evaluation, reporting practices, and morphology terminology is actually seen worldwide. Although there is no evidence that a particular reporting system is superior to the others, there is a need for global consensus guideline for grading and reporting findings on peripheral blood films as part of good laboratory and clinical practice and for use by accrediting agencies. So for the materials and methods and how this article came to be, an international group of hematologists, pathologists, and scientists with expertise in blood film morphology from different continents participated in the survey, and the results were discussed in a full-day meeting in New Orleans. This preliminary meeting resulted in a consensus agreement on red cell, white cell, and platelet nomenclature, with suggestion to include a short description of these cells and morphological abnormalities, and a proposal to develop a grading system for these cell types. Another important recommendation that came up was to use the grading and some cell morphology, the analyzer parameters, because these are more accurate and precise. Example, we can use the MCV to gauge or to check for the presence of microcytosis or macrocytosis, or check the MCH for presence of hypochromia or hyperchromia. However, the lab should establish policies regarding PBS review or blood smear review when the full blood count suggests the presence of hematological pathologies that require investigation. After an exhaustive review and analysis of the literature, the preliminary draft was circulated among the members, and it was finalized during the ICSH General Assembly meetings. There were a number of differences in opinion on nomenclature and practice, and so this document reflects a consensus agreement on nomenclature and grading between the members and is intended as a guideline only. It was also agreed upon that a database of the reference images will be provided. Not included in this guideline are recommendations for standardization of blood film preparation, staining, and examination or exhaustive description of blood cell morphology. Also, we will not be discussing the diagnostic criteria for hematological malignancies or other diseases. The grading of morphology elements should provide the clinician with useful clinical information, and so only clinically significant findings should be reported. As such, the committee recommends a two-tiered grading system of moderate or 2+, and many or 3+, with the corresponding percentages as shown in the table. And by the way, the percentage will be determined by assessing at least 1,000 RBCs. The only exception to the two-tiered grading system are the schistocytes, for which the designation of 1+ or few or rare is already clinically significant. So for the first of the three red blood cells, automated analyzers provide accurate and precise RBC counts and red cell indices. When there are flags, we have to confirm the presence of abnormal morphologic findings by microscopy. And as I mentioned, a minimum of 1,000 RBC should be evaluated. Normal RBCs are 7.5 microns in diameter, are round, slightly oval, and biconcave with a central area of pallor, and this area of pallor occupies around a third of the RBC diameter. The general recommendation is to have a qualitative report for those presenting with RBC abnormalities. However, a schistocyte count may be of clinical value. Since the committee recognizes the presence of geographical or traditional differences in morphology nomenclature, this article also provides a table for common red cell synonyms. First, we discuss the irregular distribution of RBCs on the film. Agglutination usually indicates the presence of cold reactive anti-RBC antibodies, and we only have to report the presence or absence of agglutination. Rouleau formation is usually seen in cases of pyroproteinemia. It should be assessed on the thin part of the smear, and it would look like red cells stacked up like a stack of coins. Like agglutination, we only have to report the presence of Rouleau formation. Anisocytosis is the presence of increased variability in RBC size, and the RDW from the automated analyzer can actually reflect the presence of anisocytosis. However, this is a non-specific finding. The recommendation is to use and report the RDW as a measure of the degree of variation in cell size. However, if this parameter is not available in your analyzers, then you can grade the anisocytosis manually. Dimorphism refers to the presence of two distinct cell populations. It can be seen on your red cell histogram. And again, the increased RDW would be a clue. This term is most often used with the presence of a microcytic and hypochromic red cell population combined with a normochromic, normocytic, or macrocytic red cell population. However, it can also refer to the presence of a macrocytic red cell population and a normocytic red cell population. So the recommendation is to report the presence of dimorphism and describe each population. Microcytes measure less than 7 microns in diameter, and macrocytes measure more than 8.5 microns in diameter. You will also be clued into the presence of microcytes or macrocytes if your MCV is either less than 80 or more than 100 FL, respectively. However, patient age should be taken into consideration, as the red cells of neonates and newborns are larger than those of the adults, and red cells of healthy children are smaller than those of adults. The recommendation is to use the analyzer-generated MCV to gauge the red cell size. Visual grading may be done if abnormal RDW or histogram are noted despite a normal MCV. Another important note is that oval macrocytes should be graded separately from your other macrocytes. Hypochromia refers to a reduction in staining of your red cells. If there is severe hypochromia, both the MCH and MCHC will be decreased, and this usually is present along with your microcytosis. The recommendation is to use the analyzer-generated MCH to gauge the hypochromia. Another option is to grade the hypochromia visually. Polychromatophilic or polychromatic RBCs are immature RBCs that are larger than normal with a pinkish blue-gray appearance due to the residual ribosomal RNA. The recommendation is to grade the polychromasia and to perform a reticulocyte count if necessary. By the way, when I say you have to grade certain morphology, I am referring to the table provided by ICSH. For RBC shapes, all these images came from the supplementary images provided by the article, and for most of them, the recommendation is actually to grade each shape. Acanthocytes have 2 to 20 irregularly spaced projections or spicules of variable length, thickness, and shape, and some with club-shaped ends. The recommendation is to grade acanthosis. For bite cells, same. The recommendation is also to grade bite cells. Bite cells usually occur due to the removal of Heinz bodies by the spleen, and this is a feature of oxidant hemolysis and could be morphologically identical to the keratocytes produced by MAHA or your microangiopathic hemolytic anemia and mechanical damage. Blister cells occur when the hemoglobin appears retracted into one half of the cell, leaving the remainder of the cell as an empty membrane. Echinocytes, as opposed to your acanthocytes, have fairly regular, short, blunt projections or spicules. Elliptocytes are red cells with the long axis more than twice the length of the short axis, while ovalocytes are red cells with the long axis less than twice the length of your short axis. So again, we grade the elliptocytes and ovalocytes separately. Irregularly contracted cells appear smaller, denser than the normal RBCs. However, they are not as regular in shape as spherocytes. The definition of a poikilocyte is a red cell of any shape. This is a non-specific abnormality, and since certain shapes may be associated with a particular disorder, again, the recommendation is actually to report and grade the abnormal specific cell shape rather than use the term poikilocytosis. Schistocytes, as seen in the figure, are fragments of red cells, and these are diagnostic of MAHA. They are always smaller than intact red cells, and they are produced, as mentioned, by intrinsic mechanical damage within the circulation. The recommendation is to grade schistocytes, and as we saw in the table earlier, instead of a 2-tiered grading system, it has a 3-tiered grading system. Sickle cells are crescent or sickle shaped with pointed ends, and the recommendation is to grade the sickle cells. Spherocytes, as opposed to your irregularly contracted cells, appear more regular in shape, but they are also smaller than your normal RBCs and appear denser with no area of central pallor. Stomatocytes are uniconcave and cup-shaped with a slit-like area of pallor. Sometimes you can have 2 slits instead of just 1, and it may appear the slit-like area of pallor may appear V-shaped. Target cells are thin with an area of increased staining in the middle of the area of central pallor, and again, the recommendation is to grade each shape. So you grade the stomatocytes, you grade the target cells. Finally, last of the discussed abnormal RBC shapes, teardrop cells are pear or teardrop shaped red cells, as the name implies, and you have to grade these. For inclusions in RBCs, basophilic stippling are fine, medium, or coarse blue granules uniformly distributed in the RBC cytoplasm. These are due to abnormally aggregated ribosomes. Howell-Jolly bodies, on the other hand, are single, small, dense, and perfectly round basophilic inclusions, and these are fragments of your nuclear material or DNA. Pappenheimer bodies are ferritin aggregates in RBCs that are visible in your Romanowski stain as multiple basophilic inclusions with variable size, shape, and distribution. And since these are ferritin aggregates, they stain positively for iron or Pearl's Prussian blue stain. Nucleated RBCs are your red cell precursors before enucleation, of course. So the recommendation is to count and report NRBCs as absolute count within the differential, with the WBC corrected for the presence of NRBCs, meaning your differential count will be a nucleated blood cell count instead of just your white blood cell count. Or you can also opt to count and report the number of NRBCs per 100 WBC. Intracellular hemoglobin crystals may be seen in hemoglobin C and hemoglobin SC disease. These stain densely, they vary in size, and have straight edges with pointed ends. The recommendation is to report the presence only of these crystals, so no need to grade. The presence of microorganisms should be reported. However, for malaria, you have to identify the species, and determination of parasite density is useful in clinical management and in monitoring response to treatment, particularly in Plasmodium falciparum and Plasmodium knowlesi. This is a summary of the recommendations for grading and reporting of your abnormal RBC morphological findings. For your white blood cells, the article again emphasizes that modern analyzers already provide us with accurate white cell counts and differential counts. However, these may be inaccurate in the presence of abnormal white cell populations, and so microscopic examination of a well-made, well-stained slide for accurate white cell differentiation and classification is still necessary. WHO recommends a 200 leukocyte differential count for the peripheral blood, compared to the recommendation of a 500 leukocyte differential count for your bone marrow morphology. In order to know what is abnormal, we have to first quickly discuss what is normal. For your myeloid development, it begins as a myeloblast. The myeloblast is a large cell, 12 to 20 microns in diameter, with a large round or oval nucleus with fine chromatin, and at least one prominent nucleoli with basophilic cytoplasm. This cell has no Golgi zone, and granules may or may not be present. Promyelocytes are a bit larger than your myeloblasts. They have oval or round nucleus with fine or intermediate chromatin, blue, violet, and red cytoplasmic granules, and a pale area equating to the Golgi zone may be seen near the nucleus. A myelocyte is 10 to 18 microns in diameter, and it has a round or oval nucleus, which may be eccentrically placed with a chromatin with a moderate degree of coarse clumping. The nucleoli is not seen in this cell. A moderate amount of blue-pink cytoplasm is noted. Metamyelocytes have an indented or kidney-shaped nucleus with pink cytoplasm and clearly differentiated granules, so you can already tell if they will be neutrophils, eosinophils, or basophils. Your promyelocytes, myelocytes, and metamyelocytes, and of course your myeloblasts, are not usually seen in the peripheral blood. Band neutrophils or stab cells are 10 to 14 microns in diameter, and these are neutrophils with non-segmented nucleus or rudimentary lobes connected by a thick band, and they also have pink abundant cytoplasm with small violet-pink neutrophilic or secondary granules. If the lobes of the nucleus are connected by a thin thread of chromatin, then that would be your segmented neutrophils. For band neutrophils, the recommendation is to count them as segmented neutrophils. Many laboratories do not report band neutrophils in adult patients or children due to inter-observer variation in the classification of these cells as either bands or just segmented neutrophils. However, appropriate comments may be made if increased numbers are seen or observed in the blood film. Eosinophils are characterized by their eosinophilic or orange granules that are uniform in size, and these granules are larger than the neutrophil granules. The basophils have purple-black coarse granules that more often than not obscures the nucleus. Monocytes are the largest cells in the peripheral blood, but are variable in size. Usually we see them having an irregular echidna-shaped nucleus with light blue-gray cytoplasm with fine granules and sometimes with vacuolations. Next is a short discussion on lymphocyte development and morphology. So lymphoblasts are large cells with round or oval nucleus with fine chromatin, sometimes described as glassy chromatin, with one or more nucleoli and scanty basophilic cytoplasm. Prolymphocytes are a bit larger than your lymphoblasts. However, there is less NC ratio. It has a more abundant cytoplasm than the lymphoblast and more condensed chromatin. Also, in comparison with your lymphoblast, it has a single nucleolus. Like your myeloid precursors, lymphoblasts and prolymphocytes are not usually seen in the peripheral blood. Lymphocytes are predominantly small or less frequently large with round nucleus, dense chromatin, dense clumpy chromatin, and scanty cytoplasm. But sometimes we see the LGLs or your large granular lymphocytes with prominent small red-violet granules, and normally these comprise 10 to 20% of your peripheral lymphocytes. But the recommendation is actually to count these LGLs as lymphocytes, but like the band neutrophils, if they are seen in increased numbers, you may mention that in the comments. Automated WBC differential count is more precise when there is no abnormal cell population. Additionally, if the white cell count is very high or very low, the manual differential count may actually be less accurate or reproducible. So the recommendation is to report the automated analyzer WBC differential count in patients with normal cell populations in the absence of analyzer flags or abnormal cell populations. However, if the automated values are found to be accurate after viewing the film due to flagging, the automated values may be reported. So once again, if there is a qualitative or quantitative flag, you have to review the film. If the automated differential count is actually kind of similar to your manual differential count, then you can use the automated analyzer's differential count. The article then discusses some qualitative abnormalities in myeloid and lymphoid cells. Our rods are sharply defined red rods or needle-like cytoplasmic inclusions. We have to report the presence of our rods when seen, especially in a certain hematologic disorder that will be mentioned later. Dole bodies are pale light blue or gray single or multiple cytoplasmic inclusions seen at the periphery of the white blood cell. These are non-specific reactive changes but may also be seen in Meheglin anomaly if associated with thrombocytopenia and giant platelets. Dole bodies should be graded when seen. Hypergranulation, specifically of your neutrophils, or sometimes called toxic granulation, occurs as a response to infection and inflammation. So this is a non-specific change which is a result of abnormal primary granule maturation. And sometimes you see hypogranulated neutrophils where the reduced or absent granulation causes the cytoplasm to appear bluish gray instead of pink. Both hypo and hypergranulation should be graded. Neutrophil vacuolations may be due to infection, inflammation, alcohol toxicity, or prolonged storage in tubes with EDTA, but still, these should be graded when seen. We also have to comment on the presence of hypersegmented neutrophils. The definition would be, if you see any neutrophil with at least 6 nuclear lobes, or if more than 3% of your neutrophils have 5 lobes, and you get this percentage by counting 100 neutrophils. Hyposegmented neutrophils appear when there is a failure of normal nuclear lobe development and should not be confused with immature granulocytes such as your metamyelocytes. These are smaller with lower NC ratio and coarse clumped chromatin. The recommendation is to count them as mature segmented neutrophils, but always with a suitable comment in your peripheral blood film report. Leukemic myeloblasts vary in appearance, and the recommendation is just to count them as blasts. No need to specify if it's myeloblast, and describe them in the film report. Abnormal promyelocytes may have bundles of your Auer rods, and the recommendation is actually to count them as blast equivalents in the differential, but it is important that a suitable description of the abnormal promyelocytes and an interpretive comment be added to the film report. The likely diagnosis of APL, or acute promyelocytic leukemia, should be communicated directly to the clinician. Monoblasts are large cells with fine chromatin and 1 or 2 prominent nucleoli. These should be counted as blasts and described in the film report. Promonocytes are large cells with indented or convoluted nuclei. Promonocytes should be counted in the differential with a comment on their presence in the film report. However, if you are assessing the film for or making a diagnosis of AML, promonocytes should be counted as blasts. Abnormal monocytes are produced due to bone marrow stress or stimulation, for example, infections or growth factor administration. They appear as large cells with increased NC ratio, more delicate chromatin, prominent nucleoli, and increased vacuolation. Abnormal monocytes should be counted as monocytes with a comment on their morphology and a suitable comment. Dysplastic changes may be seen in your peripheral cells. However, we only have to comment on the presence of dysplasia, and we do not have to grade the dysplasia, as that should be done in the bone marrow smears. Due to the widely variable lymphocyte morphology and confusion of certain terminology such as variant reactive abnormal lymphocytes, or even the combinations of cells, for example, monocytoid lymphocytes or plasmacytoid lymphocytes, ICSH recommends the use of only 2 terms. Reactive lymphocyte if you are suspecting a benign etiology, or abnormal lymphocyte if you suspect that the etiology is malignant or clonal. However, there should always be a comment or description of the cells. If you see just a few reactive lymphocytes, then you can just comment on their presence. If they are seen in significant numbers, then we can actually count them as a separate population from your lymphocytes. At this point, the article reiterates that a comprehensive classification and description of lymphocytes in malignant lymphoid neoplasms is beyond the scope of this article, so we are referred to the WHO classification of hematolymphoid tumors. But if we can identify abnormal lymphocytes as a particular neoplastic cell type, for example, plasma cells, hairy cells, or lymphoma cells, then we can count them as that particular cell class. And the use of this nomenclature underlines the limited diagnostic value of PBS morphology in the diagnosis of lymphoproliferative neoplasms, because the final diagnosis is determined by immunophenotyping, by flow cytometry, and sometimes even with additional molecular or cytogenetic studies. Hairy cells have abundant blue-gray cytoplasm with fine hair-like projections. So, if the patient has not been diagnosed yet with hairy cell leukemia, then we can count them as abnormal lymphocytes on first presentation. However, if the patient has had immunophenotyping done, then we may count them as hairy cells, separate from your lymphocytes in the differential. The description of lymphoma cells for specific for lymphoproliferative neoplasms again would be better described in your books, your WHO classification of hematolymphoid tumors. The takeaway from this part is just that you have to count them as abnormal lymphocytes on first presentation, like your hairy cells, with a detailed description of the cells in the film comments. And again, like your hairy cells, after immunophenotyping, you may count them as lymphoma cells in the differential, the WBC differential count. Plasma cells have eccentrically located nuclei with clumpy chromatin and abundant basophilic cytoplasm. The recommendation is to count them as a separate population in the WBC differential. So, no immunophenotyping required for this one. Prolymphocytes were mentioned in the lymphoid development and morphology. What is shown here are cells from your B prolymphocytic leukemia. These are counted as a separate population in your WBC differential. Next, we have the smudge cells or smear cells, which are disrupted nuclei of your fragile cells. ICSH actually recommends to count the cell from which they are derived. If the nature of the smear cell is apparent, however, admittedly, I think that would be too difficult. So I would just do the second part, that if large numbers are seen and I am suspecting a CLL, then I'll just report the differential and then comment on the presence of smudge cells. Leukemic lymphoblasts, like your myeloblasts, can just be counted and reported as blasts with an accompanying description in the film report. So these are the summary of the recommendations for grading and reporting of your WBC morphologic findings. Finally, we go to the grading of morphological features of the platelets. Platelet size should be considered in relation with the platelet count. Normally, they are 1.5 to 3 microns in diameter, so they should be around half or less than half the diameter of an RBC. Large platelets may actually be seen normally. These are around the size of an RBC. In the peripheral blood, large platelets should be less than 5% of the platelet population. Giant platelets are larger than your RBCs. They are 10 to 20 microns in diameter as seen in the center of the image. So the recommendation is to comment about the platelet count and presence of small, large, and or giant platelets. Additionally, although it was not mentioned in the article itself, they provided a table or a grading system for your giant platelets. So you should also report that. It should also be noted that platelet size increases gradually during storage in EDTA tubes. So in addition to causing vacuolations in your neutrophils, EDTA can also cause increase in platelet size. Hypogranular platelets have little, if any, of the purple-red granules. As seen in the upper left of the image, you have your hypogranular platelets. So the recommendation is to report the presence of hypogranular platelets if seen in the film. No need to grade these platelets. Lastly, we have to report the presence of megakaryocytes, megakaryocytes, and micromegakaryocytes if seen. A micromegakaryocyte is roughly the same size as a promyelocyte, and it has a non-lobated or bilobed nucleus with a variable amount of weakly basophilic cytoplasm, occasional cytoplasmic vacuoles, and variable numbers of granules. So this is a summary of the recommendations for grading and reporting of morphological findings in your platelets. And again, this is the grading system for your giant platelets. In summary, these recommendations address the need for a global standard in naming, grading, and reporting abnormal cells or morphological abnormalities observed at the time of the peripheral blood film review and manual differential counts. The primary goal is to provide clear guidelines to achieve reliable and reproducible results in laboratory analysis and in diagnostic hematology. The committee recognizes the existence of some traditional and geographical differences in nomenclature, so that favors some flexibility in the suggested methods of reporting for a number of parameters. I think this is the last slide, so once again, the article will be linked in the description, and feel free to ask any questions or write down any comments, and I'll make sure to read them. And I'll hopefully see you in the next video. Thank you very much for listening.